I will discuss the questions of CBT 1 for this FMGE, and the exam is in July. So these are the two CBT tests, CBT 1 and 2. So we'll discuss the questions of surgery. Okay, so the first question: adequate treatment of a gallbladder cancer involving the lamina propria. Okay, so if the gallbladder cancer involves the lamina propria, means it is T1A cancer. And if it is a T1A cancer, then only cholecystectomy is good enough. Suppose it is going beyond the lamina propria, it involves the muscle or serosa or outside the serosa, then we have to go for a radical or extended cholecystectomy. Okay, so if it goes beyond, then we'll go for a extended or radical cholecystectomy. Okay. Okay, so option number D is the answer. Next, we'll see which of the following drugs is not recommended for the perioperative management of thyroid storm. See, thyroid storm occurs when you don't prepare the patient adequately if the patient is having hyperthyroidism or thyrotoxicosis. So during the surgery, it can release very high T3, T4, and it can lead to thyroid storm, and hyperpyrexia is very common. Propranolol is given. Propylthiouracil is the antithyroid drug of choice. Iodine solution like potassium iodide, sodium iodide can also be given. But aspirin is not used. Okay, aspirin we don't use in the thyroid storm. See, aspirin, when there is increased temperature, for increased temperature we give paracetamol. Okay, paracetamol or acetaminophen is used. Aspirin, they say that giving aspirin can increase the T3, T4, so that's why we don't give aspirin in these cases. Next question: 25-year-old male, von Hippel-Lindau syndrome found to have bilateral adrenal mass. Okay, so von Hippel-Lindau adrenal mass, it is pheochromocytoma. Pheochromocytoma, bilateral pheochromocytoma is common in VHL syndrome. You can see on the imaging also. Can you see this? Okay, can you see these two adrenal masses? His medication list includes ACE inhibitors and calcium channel blocker. As part of the pre-op preparation, what medication should he receive? So we know in pheochromocytoma, first we give alpha blocker and then we give beta blocker. Alpha blocker of choice is phenoxybenzamine. Phenoxybenzamine is the alpha blocker of choice. Which of the following is the best parameter for monitoring septic shock? Okay, so in septic shock patient, the best parameter, there are certain clinical parameters and certain parameters we see at the tissue level. At the tissue level, this serum lactate is very important. Okay, serum lactate less than 2 millimole per liter. If this is less than 2 millimole, then we'll say that the patient is getting better and patient is out of shock. Okay, so serum lactate is serum lactate. Other parameters you can see is base deficit. Again, it is a measure of acidosis. Mixed venous oxygen saturation, serum lactate. These are nowadays the three important, you can say, the parameters which are looking at the tissue level. At the tissue level, whether the cells are getting the oxygen sufficiently or not, we can see by these three things. Fibrous plaques in the Peyronie's disease originating. Okay, so Peyronie's disease is a condition in which there is fibrosis occurs in the tunica albuginea surrounding the corpora cavernosa. Okay, tunica albuginea is the outer part of the corpora cavernosa, and if there is there is fibrosis occurs, then the penis will deviate to one side. Okay, so this is deviation of penis. The exact cause is idiopathic in Peyronie's disease, but they probably, I mean, the most common reason these days they say is this is a type of healing disorder. This is abnormal healing disorder. Buck's fascia is the outer part, is the covering of the penile shaft. Corpora spongiosa is not involved because corpora spongiosa is having urethra inside it. Okay, the erectile tissue is there in the corpora cavernosa, and the tunica albuginea is the outer covering of the corpora cavernosa, and in that if there is fibrous plaque deposition, it leads to Peyronie's disease. Next question, newborn infant respiratory distress 4 hours after delivery, tachypnic, sternal subcostal retraction, decreased breath sounds, and the bowel sounds are present on the left side of the chest. Chest x-ray is given. You can see the chest x-ray. You can see the scaphoid abdomen. So this is very obvious congenital diaphragmatic hernia. Congenital diaphragmatic hernia, which can be of two types, so Morgagni and Bosdalek. Bosdalek is more common. Okay, Bosdalek is more common. Morgagni is not that common. Okay, it is also big defect and it is present in the left posterolateral wall of the diaphragm. Which of the following is not a part of management of this newborn? See, when suppose this is the defect in the diaphragm and through which the abdominal content like intestine goes into the thorax, and this side lung, like the left side lung, will be hypoplastic. So when we manage the patient, the main focus is not on the immediate repair. Okay, you have to, because the child is in respiratory distress, so you put the endotracheal tube and give oxygen. When the child is very sick, we can put the kid on ECMO. Inhaled nitric oxide is also important. It will decrease the pulmonary artery pressure and it will, I mean, now the blood will start going to that side of lung. Otherwise, generally the blood does not go to that lung because of the increased pulmonary pressure. And inotropic and vasopressor support can also be required because of the severe respiratory distress leading to heart dysfunction, and that leads inotropes and the vasopressor. Immediate operative repair is not recommended. Operative repair is done usually after 48 to 72 hours when you stabilize the child, and then you put the intestine back into the abdomen and the lung will take time to expand. Okay, so immediate operative repair is not required. Select the most appropriate site for the initial trocar placement in a patient undergoing laparoscopic fundoplication, the previous midline scar. Okay, so see, in normal conditions, normal patient who has no previous abdominal surgery, the initial site of trocar placement is around the umbilicus, either above the umbilicus or below the umbilicus. So here you put the viris, and then here you put the first trocar, and then you put the endoscope, and the remaining trocars you can put under vision. But this question is about a previous midline scar. Okay, so suppose now this is a patient who is having a midline scar. So if there is a midline scar and you try to put the viris or the trocar from the umbilicus, there are very high chances that there is some adhesion of the bowel there and you can cause injury. So in these cases, either you use a open technique. Okay, previous abdominal scar, either you use a open technique of putting the trocar, that is known as Hassan's technique, or you can put the viris needle here. This is known as Palmer's point. Palmer's point is also a safe area. So that is left upper quadrant in the mid clavicular line, just 1 finger breadth below the left costal margin. Okay, so after putting the viris and the first trocar at Palmer's point, you can put the other things, because now you will put the endoscope inside. Now inside everything will be seen, and you can put the other trocar safely. Okay, so that's why the answer is option number C. Which of the following patients do not meet the criteria for referral to a burn center? Okay, referral to a burn center, we send the patient to a burn center if there is, see, I'll tell you the thing. If there is a partial thickness burn more than 10%, all full thickness. Okay. If there is a burn on face, neck, genitals, hand, feet, major joints. Okay. And if there is any chemical burn, electric burn, if there is inhalational injury, airway injury, and I'll write here burn with trauma, and burn in patient with comorbid condition. Like suppose the patient is having some you can say MI or some severe respiratory disorder, COPD and all, it is better you send the patient to a specialist, you can say the burn center. So let's see option. 1% burn but left hand. So we have to send. Bilaterally on the knees, we have to send. 25-year-old, 7% partial thickness, not fitting in our criteria. Carbonaceous sputum after intubation, it means there is inhalational injury. So option number C is not fulfilling any of the criteria for referral to a burn center. Which of the following is not true regarding the laparoscopic hernia repair? See, laparoscopic hernia repair always occurs in general anesthesia. Always in general anesthesia. You cannot use local anesthesia. Open hernia, you can do local anesthesia, you can go for local anesthesia or the spinal anesthesia, but laparoscopic hernia is always general anesthesia. So this is the wrong statement. It could lead to injury to the, yes, it can lead to injury to the femoral branch of genitofemoral nerve, lateral femoral cutaneous nerve, anterior femoral cutaneous nerve, and the femoral nerve. Okay, so all these nerves are present in the triangle of pain. Okay, it can cause injury. Transabdominal preperitoneal, this is TAPP, or total extraperitoneal, that is TP, are commonly used. Yes, we use these two approaches for the laparoscopic groin hernia, that is indirect, direct, and femoral hernia. And it is best suited for recurrent and bilateral hernias also in females. So in which case laparoscopic hernia is preferred, recurrent bilateral hernia, and in females the laparoscopic approach is better. Okay, otherwise you can go for open also, lap also, but in these three conditions laparoscopic is preferred. A 5-week-old boy, 5-day history of non-bilious vomiting, weight loss, and fontanelle is flattened, mucous membrane is dry, means the patient is having dehydration. There is hypokalemia, hypochloremia, and metabolic alkalosis. Abdominal X-ray is shown, it is showing single bubble sign. So all these things, everything is going in favor of a condition known as infantile hypertrophic pyloric stenosis. Infantile hypertrophic pyloric stenosis, in which the muscle, the circular muscle in the pylorus is thickened, and because it is thickened, and you can see in this area, and the bile is opening in the second part, so that's why when the vomiting occurs it will be non-bilious vomiting, because the bile is not going in this part, non-bilious vomiting. So let's see the option. Which of the following statement about this infant is true? Characterization of the emesis as non-bilious is crucial. Yes, it is crucial, because if it is bilious it can be because of duodenal atresia. Okay, so this is true statement. Ultrasound will not add to the diagnosis. It is wrong. Ultrasound is in fact the investigation of choice. It will show the thickening at the pylorus more than 4 mm and the length of that thickened area is more than 16 mm. This condition is 4 times more common in males as compared to females, and especially the firstborn child are affected. Lab results are likely to demonstrate the most common electrolyte abnormality is hypokalemia, hypochloremia, metabolic alkalosis with paradoxical aciduria. Okay, so this is the electrolyte abnormality. Okay, so these three statements are wrong. Option number A is correct. Option number A is correct. Next, we'll see proximal muscle weakness, polyuria, depression, calcium is high, PTH level is also high. Normal PTH is 15 to 65 picogram per ml or nanogram per liter is the same thing. Which of the following is the investigation of choice for pre-op localization? Okay, so all these things, muscle weakness, polyuria, depression, hypercalcemia, increase in PTH is going in favor of primary hyperparathyroidism. And primary hyperparathyroidism, most commonly it is due to parathyroid adenoma. So parathyroid adenoma, the treatment is we need to just remove the parathyroid adenoma. So before removal, you have to know that out of 4 parathyroid, which parathyroid gland is having the adenoma. And for localization, the investigation of choice is technetium-99 SESTA-MEB scan. SESTA-MEB is a nuclear scan. We give this nuclear isotope, and the oxyphilic cells of the parathyroid will take up this, and it will be shown after 2 hours that which out of 4 which gland is involved. Patient with undescended testis. Let's see the option. Undescended testis should have orchidopexy within first 3 months. See, within first 3 months there are very high chances of spontaneous descent. Okay, so spontaneous descent is seen in 80% of the undescended testis in the first 3 months. So you should wait and watch in this period. Surgery should be done between 6 to 12 months. Okay, surgery you will do between 6 to 12 months. That is the ideal time. Need orchidopexy to decrease the incidence of testicular cancer in the future. Yes, see, orchidopexy, when you decrease the suppose undescended testis, risk of cancer, you can say 40 times increase risk as compared to general population. But if you do orchidopexy, then the risk of cancer is 4 to 5 times increased risk. Okay, it will be there is some increase of risk of cancer even after orchidopexy. Suppose the parents will ask, okay, now there is no risk. You will say there is a risk, but the risk is much less as compared to if you don't do the surgery. Okay, so this is correct. Have no difference in the fertility compared with the normal population if the other testis is normal in position. Okay, so you can see if there is bilateral undescended testis, then definitely, because it will not cause spermatogenesis, so there will be decreased fertility. But if the other testis is normal in position, then the fertility will be normal. So you can say this statement is also correct, partly correct. Can be successfully treated with hormone therapy alone? No, you have to do the orchidopexy. So now you can say both B and C looks good. But I'll say B is a better answer, because if you do orchidopexy, the incidence of testicular cancer is decreased. And this orchidopexy should be done within 1 year. Beyond 1 year, the risk is raised. Beyond 1 year, there is risk. But the problem is, why we do beyond 1 year? Because when you bring it down, then the chances of detecting the cancer, if it occurs, that is better. So that's why no matter at what age the patient or the child is coming to you, you have to do orchidopexy. Although after 1 year the risk of cancer will not be decreased significantly, but it will be diagnosed at an early stage. Okay, it will be diagnosed at an early stage. So option number B and C both are correct in this question. Both are correct. Which of the following statement regarding bariatric operation is not correct? Okay, so bariatric surgery is for morbid obesity. For morbid obesity patients, we do this bariatric surgery. And morbid obesity means either BMI is more than 40 or more than 35 with comorbidity. So bariatric surgery you can divide broadly into restrictive procedure and malabsorptive procedure. Okay, so few procedures are only, okay, I'll write here restrictive. The most common restrictive procedure done these days is sleeve gastrectomy. This is overall the most common bariatric surgery done. Then adjustable gastric banding. And vertical, well, there is one vertical band gastroplasty, but although that is not done these days. So these are purely restrictive procedure. Now few surgeries are mostly, or you can say mainly restrictive, mildly malabsorptive. Mainly restrictive, mildly malabsorptive. In that comes Roux-en-Y gastric bypass. And the third category is mainly malabsorptive, mildly restrictive. In this comes two procedures, biliopancreatic diversion and duodenal switch. Okay, so these are the, you can say, 5 types of bariatric surgery which are commonly done these days, although there are few new also coming, mini gastric bypass and all. But these are the main type. So let's see, laparoscopic adjustable banding is restrictive procedure. This is true. True. Biliopancreatic is mainly malabsorptive. True. Roux-en-Y is mainly restrictive with malabsorptive. That is true. Sleeve gastrectomy is a malabsorptive. This is wrong. Sleeve gastrectomy is a restrictive procedure only. And that's why this is our answer. Although this is the most common type of bariatric surgery done these days. 42-year female, dysphagia and esophago, I mean the endoscopy, manometry is normal, and you ordered a CT which helps to diagnose her dysphagia lusoria. Okay, so dysphagia lusoria is a condition in which there is some abnormal blood vessel compressing the esophagus leading to dysphagia. And the most common reason for that is right subclavian artery arising from the descending thoracic aorta. This is known as aberrant right subclavian. Aberrant right subclavian artery arising from the descending thoracic aorta. Okay, so this is the most common reason for dysphagia lusoria. An otherwise healthy 40-year-old man, because of hematemesis after a night of binge drinking and retching, and upper GI endoscopy shows this image. Okay, so this is the proximal part of the stomach, and you can see there is a ulceration. This is very classical, the history and the image, Mallory-Weiss tear or Mallory-Weiss syndrome, in which there is just a mucosal tear in the proximal stomach at the cardia. This is the cardia part, cardia of stomach, only mucosal. It is not full thickness and can lead to upper GI bleeding. Now most of the bleeding will stop on its own. Let's see the option. It is caused by pulsion. Pulsion diverticulum is Zenker's. Okay, we are not talking about esophagus here. Zenker's diverticulum will not cause bleeding. Endoscopy should not be performed. Endoscopy is in fact the investigation of choice. Bleeding is from arterial source. This is true statement. It is the bleeding from the arterial source in the proximal part of the stomach where the tear occurs. This is the area which is supplied by left gastric artery. So it is the bleeding from one of the branches, small branches of the left gastric artery. Surgical resection is not often required. Most of the time, more than 70% of the time, bleeding will stop on its own. If it continues, then endoscopy will take care of the bleeding. Surgery is very rarely required. If endoscopy is not available or the endoscopy fails, then only surgery is required. So option number C is the correct answer. 30-year-old pregnant females present to the emergency, right upper quadrant abdominal pain. WBC is high. Ultrasound was done, shown normal gallbladder and fetus is also viable. Appendix is not visualized. See, 28 weeks means third trimester. In third trimester, most of the abdomen is occupied by the gravid uterus. And because of this, the things are shifted upwards, which are normally present in the lower abdomen. And one of that thing is appendix. Okay, so if appendicitis occurs, instead of pain in the right lower abdomen, there will be pain in the right upper abdomen, which is shown in this question. Also in the hint, what are the other reasons for the upper abdominal pain? Okay, gallbladder, but the gallbladder is normal. WBC is high. Okay, so this is basically a appendicitis in a pregnant patient. So obtain a CT. See, CT is a radiation. In pregnancy, no radiation. Treat with antibiotics and attempt to avoid an operation. See, if appendicitis occurs in pregnancy, that is in fact one of the most common non-gynecological reason for pain abdomen in the pregnancy, appendicitis. And you have to do surgery. Okay, no conservative management in pregnancy, because if it ruptures, then the fetal loss is very high. Proceed with laparoscopy after delivery. See, this you can do in proceed with laparoscopy, but don't wait till delivery. Laparoscopic treatment you can do in second trimester, because at that time the uterus is not that big and the risk of fetal loss is also less. Patient is in third trimester. Obtain a MRI. This is correct. MRI is safe in pregnancy, and proceed with an appendicectomy if positive. This is also correct. So option number D is correct. You have to do surgery. If ultrasound is like in this case it is not confirmatory, then you can go for MRI, and MRI will tell you that there is appendicitis and you go ahead and treat. No conservative management in pregnancy. What is the appropriate surgical repair for the type of choledochal cyst shown in the MRCP? See, if you can see this, suppose this is the liver, these are the right and left duct, this is the gallbladder. This is supposed to be the CBD, which is dilated like this. Okay, so this is the fusiform dilatation of the CBD, the most common type of choledochal cyst, type 1 choledochal cyst. This is the most common type. And the treatment of this is, suppose this is the cyst, you have to do the resection like this, and this hepatic duct you need to anastomose with the jejunum like this, in a Roux-en-Y type of hepatico-jejunostomy configuration. Okay, so the treatment is hepatico-jejunostomy. You have to remove that choledochal cyst. It also increases the risk of malignancy of the whole biliary tract. 58-year-old man presents to the clinic with a 2-month history of the sensation of urinating air. The patient is saying that every time he is passing urine, he feels as if he is urinating air. There is bubbles coming in the urine. History of diverticulitis. What is the most common fistula? See, suppose we know that diverticula is in the colon, is most commonly seen in the sigmoid colon. And this area is very close to the urinary bladder also. So sometimes there is abnormal communication occurs between the bladder and the fistula. So now because it is colon, it has the air, so this air can go into the bladder, and that's why the urine comes with, the air. This is known as pneumaturia. Okay, air in the urine is pneumaturia. So the reason for this is colovesical fistula. Colon, vesicle means bladder, fistula is fistula. Okay, colovesical fistula. In fact, this is the most common fistula you will see in case of diverticulitis. In case of diverticulitis, most common fistula is this colovesical. All these fistulas can occur, colovaginal and cutaneous, but the most common is this colovesical fistula. Treatment of that is you do a diverticulate, you do remove the sigmoid colon and repair the bladder, patient will be fine. A 23-year-old thin female, 92 pounds is like around 50 kg, less than 50 kg. History of surgical correction of scoliosis. Thin scoliosis, patient is having postprandial epigastric pain, fullness, nausea, vomiting, and thin physique. Barium shows dilated duodenum and stomach. You can see this is the barium, this is stomach, this is the duodenum. First part, I'll write D1, second part D2. But from the third part, you can see that the dye is not going. Okay, so which of the following is the operative management of choice? So this condition, all these things are going in favor of the condition known as SMA syndrome, also known as Wilkie syndrome or the CAS syndrome. In this case, suppose this is the aorta. Aorta gives this SMA, superior mesenteric artery, at the level of L1 vertebra. Normally the angle of this is, you can say 35 to 65 degrees. But if this angle is low, if this angle is less than 25 degree, then what will happen? This SMA will, this is the SMA, now the angle is less, will compress the duodenum. SMA compresses the duodenum, and that will lead to intestinal obstruction, which is very clear cut given in this case. Not a congenital condition, acquired condition seen in people where there is rapid loss of weight, thin individuals, scoliosis, all these things are given in the history. So this is SMA syndrome. The treatment of SMA syndrome is, if the patient is not very serious, you can ask the patient to gain some weight, because there is some fat pad present between this SMA and the duodenum. So if that fat comes, it will act as a shock absorber, it will act as a cushioning effect, and it will not compress the duodenum. So if they gain weight and the fat comes, it is okay. Otherwise, the treatment option is duodenojejunectomy. Okay, you don't do anything to the SMA, just bring the jejunum proximal to that SMA and anastomose with the proximal duodenum. Okay, so this is duodenojejunectomy, or you can go for a duodenojejunectomy can also be done. And there is sometimes a surgery that is known as Stronk's surgery, in which you will divide the ligament of Treats, and that will increase this the angulation. Okay, here the answer is duodenojejunectomy. Intraoperative PTHSA provides guidance that all hyperfunctioning gland has been removed during the parathyroidectomy. What criteria is used to indicate satisfactory resolution of hyperthyroidism? So this question is about Miami's criteria. Okay, more than 50% in 10 minutes. So that is the answer. Drop in the serum PTH more than 50% 10 minutes after the removal of the parathyroid tissue is basically, this indicates that you have removed the disease. Surgeon, good knowledge of various types of suture needles and their utility. Which of the following description of needle type is most appropriate? Taper cut needle for suturing of, see, liver is a very friable tissue. For liver you use a, first of all, blunt tip and round body needle. Round body needle. Taper cut means it is having a cutting component and it can increase the bleeding. So this is wrong. Blunt for ligament repair. Ligaments are thick structures. Okay, for thick structures you need a sharp tip needle. Sharp tip. Blunt tip only for the friable things. Reverse cutting for mass closure of the abdominal wall. See, mass closure of the abdominal wall, there is you can say there is fascia, there is peritoneum, so it is a thick layer. Okay, so for abdominal wall, peritoneum is also there, muscle is also there. If you use a cutting needle for these things, it will not be good. Here also you use round body. Round body for bowel anastomosis is true. For bowel anastomosis, vascular anastomosis, basically for any delicate structure, you use round body. Cutting needle you use for tough structures like skin, ligament, tendon. For these things you use a cutting needle. Next question, 40-year-old man, pain with defecation and extremely intense pain, passage of the stool persists for hours. He is barely able to tolerate examination because it is painful. Small defect in the anoderm at 6 o'clock position, posterior midline. This is very typical of acute anal fissure. Which of the following is true? Most lesions are located above the dentate line. This is false. It is below the dentate line, and that area is pain sensitive. Above the dentate line is not pain sensitive. Always located, always, it's not, it's mostly located at the posterior midline. It can be seen laterally also, especially in Crohn's disease and tuberculosis, it can be lateral. The operation of choice for this is posterior internal. It is not posterior, it is lateral internal sphincterotomy. Sphincterotomy. Few fibers of the internal sphincter we divide in those cases where the this fissure is not healing on its own. Otherwise, mostly the fissure heals on its own. Pharmacological therapy with nitroglycerin, calcium channel blocker, or botulinum may prove beneficial. Yes, these things will decrease the anal tone, and if there is decrease in anal tone, patient can pass the feces and this will heal on its own. Okay, so option number D is correct. With regard to the neonatal defect of the abdominal wall, which statement is correct? See, there are two anterior abdominal wall defect. One is known as omphalocele, in which it is covered by a membrane. At the level of umbilicus, it is covered by a membrane. Another is gastroschisis, in which there is a defect lateral to the umbilicus and the bowel content is coming out. Okay, it is not covered by anything. Gastroschisis. So herniated bowel covered by membrane, no. Frequently associated, see, option number C is correct. Omphalocele is more commonly associated with chromosomal abnormalities, cardiovascular defect. Gastroschisis, the associated defects are very rare. If at all it is present, it will be intestinal atresia. Omphalocele defect is mostly to the right. There is no umbilicus in omphalocele. It is about gastroschisis, that defect is mostly to the right. Option number C is correct. 38-year-old mechanic, emergency, and air fluid level consisted with the stomach being, so this is basically traumatic diaphragmatic injury. Traumatic diaphragm injury, which is true. Right sided is more common. No, it is more common on the left side. 30% incidence of coexisting pelvic fracture. Pelvic fracture can be seen, but around 5 to 8% it can be associated with pelvic fracture, although this statement is not very important. The best initial assessment of this type is fast. Fast may we see the free fluid. In this case, there is hardly any free fluid. In diaphragm repair can be done with primary repair. Yes, for the small defects, it is primary repair. For the large defect, you can put a mesh. So option number D is correct, which is incorrectly matching the grading scale. In the model for end stage liver disease, we see creatinine, bilirubin, and INR. So they are saying creatinine. This is correct. CTP score, will see PTINR, will see bilirubin, will see albumin, will see ascites, and hepatic encephalopathy. So bilirubin, this is correct. CTP, INR, you can see child Turcotte Poo score. INR, we see, that is correct. MELT score, creatinine, bilirubin, INR, no albumin. So this is wrong. This is wrong. Option number D is our answer. That statement is wrong. Okay, so next question, patient, elderly patient, COPD, and there is rectal prolapse. So rectal prolapse, there are two types of treatment. One is abdominal approach and one is perineal approach. Although abdominal approach is more preferred because the chances of recurrence is less in abdominal approach, but abdominal approach, abdominal surgeries are big surgeries. Patient need to put under general anesthesia. Perineal surgeries, although the risk of recurrence is high, but those patients who are like elderly, who are having comorbid condition which makes them unfit for general anesthesia, this procedure is preferred. And our patient is typically fitting in this criteria. So this is perineal surgery. Perineal, you can say the surgery. Perineal surgeries, there is Thiersch-Wiring, there is Delorme's approach, and this is rectosigmoidectomy, which is also known as Altimere's surgery. The name of this surgery is Altimere's surgery. Which pathologies of the breast is correct? Breast cyst is aberration of normal development and involution. This is true statement. This is Andy of the lobule. Nipple areola complex is spared. When we do simple mastectomy, we remove the skin as well as the nipple areola complex. Early menopause is a risk factor. It is late menopause which is a risk factor. Invasive ductal cancer is more than 80% of the breast cancer. So the correct answer is A. Nodule on the right lobe, thyroid scan is done. You can see this part has not taken, so this is a cold nodule. Chances of malignancy is approximately 15 to 20%. Yes. FNAC is done. Yes. Most malignant nodules are euthyroid. Yes. Sweating and tremor are commonly seen in hyperthyroid patient, and in hyperthyroid patient you will see hot nodule. Okay, so option number B is not correct. The breast receives its blood supply. Internal mammary artery or the internal thoracic artery is the main blood supply, so this is correct. Intercostal artery is correct. Thoracoacromial artery is correct. It does not take supply from the superior epigastric artery. The last question, which of the following concerning breast cancer staging is correct? Stage 1 tumor have no metastasis to either lymph nodes or distant sites. This is correct. Stage 1 is T1 N0 M0. Okay, so this is true. Stage 3 tumors are locally advanced breast cancer. If there is distant metastasis, it will become stage 4. Okay, so this statement is wrong. Inflammatory carcinoma is T4 disease. This is correct. It is T4D. This is correct. N4, there is no N4 disease. There is no N4 disease. Okay, so unfortunately in this question also there are two options are correct. That is option number A and option number C. Okay, both are correct in this question. But better answer, I will say option number C is better. It is more obvious. Okay, so these were the questions of CBT 1 of surgery, and all the very best for your exams.